Just check my sound if my sound is okay.
Yes, your sound is okay, sir.
Professor, start coaching.
Yeah. Welcome to all for this excellent webinar, Back to Basics with Dr. Tushar Shah. I, Dr. Pragnesh Shah, President of Federation of Family Physicians Association of India, welcome you all. Federation of Family Physicians Association of India is existing since 1986 and very much active in academic, scientific and social platform throughout the nations, having almost 39 units across the India. Without taking much time, I directly request Dr. Vibhagar Adharu sir to introduce Dr. Tushar Shah sir. Dr. Vibhagar Adharu sir, please.
Thank you, Dr. Hello. Thank you, Dr. Pragnesh. Good afternoon, everybody. I have a proud privilege of introducing Dr. Tushar Shah. Dr. Tushar Shah, an MD physician, is practicing at Advanced Multispeciality Hospital, Vile-Parle West, since 1990. He graduated from Nair Hospital, Mumbai. He is a passionate teacher whose innovative methods of imparting medical knowledge have made him very famous. He is amongst the most popular teachers of the family physicians. He practices what he preaches and inspires us to do the same. He has created a cadre of family physicians who practice evidence-based medicine. His interest in teaching has enabled him to form a Telegram group avidly followed by over 2,000 doctors, where he uploads and videos and updates regularly. His passion for teaching can be judged from the fact that he has conducted webinars even while he is out of Mumbai on vacation. He has personally treated nearly 900 indoor COVID patients. His team of 10 doctors has formally managed over 15,000 COVID cases on an OPD basis. Amongst his other qualities, he is a poet and a humorist, having contested in the finals of the Laughter Challenge show on Star One. Friends, I invite Dr. Tushar Shah for his talk on OPD Neurology for family physicians. Thank you. Dr. Tushar Shah, please. Sir, unmute karo, sir.
I'm so sorry. Thank you, Dr. Vibhagar, Dr. Pragnesh, Dr. Preeti, for inviting me to start a series, which I think will be very interesting. This is the first of the series. What we want to do is that probably every second Tuesday of every month, we want to cover one system in about an hour, the salient parts of one system for outpatient medicine. So today's topic is outpatient neurology for the family physician. So what I would request Enlace Code Technology to give me the control of the PPT so that I can start the lecture. If there is any technical issue, I can of course start the lecture without the PPT. The topics that we want to cover today in neurology, outpatient neurology, are common topics like migraine, both prophylaxis and treatment of acute migraine, essential tremor, restless leg syndrome, headache of some other forms, especially the forms that can be red flags. So these are some broad areas to cover, and it'll be very interesting to for you to also ask me questions, because there'll be so many questions. I would request all of you to keep a pen and paper ready so that I can so that you can take questions. So let me start first with a topic that we call restless leg syndrome. Restless leg syndrome is, of course, a diagnosis which is made clinically. There are no confirmatory tests for the disease. It is one of the most wrongly diagnosed outpatient neurological disorders. Multiple sclerosis being the other wrongly diagnosed outpatient disorder. Multiple sclerosis is uncommon in India. So, but restless leg syndrome is fairly common, and we should not miss the diagnosis. The diagnosis is often missed principally because we treat leg pain as cramps, or meaning which is called nocturnal cramps, or hypokalemia, hypocalcemia, or spinal disease, and we miss the bus. The most important thing about restless leg syndrome is the symptomatology. This is what the patient will say. डॉक्टर साहब मैं महीनों से सालों से तंग आ गया हूँ, रात को सोता हूँ तब मेरे पाँव ऐसे इरिटेट करते हैं मुझको कि मुझे बैठना या खड़ा हो जाना पड़ता है, और मैं चलता रहता हूँ, बैठा रहता हूँ, खड़ा रहता हूँ, जैसे ही सोता हूँ मुझे फिर से पाँव में एकदम अजीब सी थोड़ी टिंगलिंग बोल सकते हैं, थोड़ा थोड़ा डिस्कम्फर्ट बोल सकते हैं. The most important question to ask the patient is this discomfort or is this uh, pain? If they say it is pain, predominantly दर्द होता है या क्रैम्प की तरह ऐंठन आती है, meaning the toes kind of bend over each other, then this is not restless leg syndrome. Restless leg syndrome is devoid of pain, and it is mainly an unusual restlessness in the legs, which sometimes the patient cannot describe. And therefore, sometimes the patient will use the word dard hota hai. You have to be a little more careful about dissecting this particular symptom. So you will diagnose it when you find restless neck. It is always bilateral, almost never unilateral. For example, nocturnal leg cramps are unilateral. Sometimes tetany or carpopedal spasm can be unilateral, but restless leg syndrome is universally bilateral. So this bilateral uneasiness, which occurs when they lie down, whether it is afternoon or night, and which improves almost immediately, dramatically improves, sometimes goes away, sometimes improves dramatically when they stand up or they start walking, then you have a clinical diagnosis of restless leg syndrome. These patients in the night are uncomfortable. If they do get sleep, maybe due to some medicines, they will also have one more feature which may be picked up by the partner or by the patient themselves, and that is periodic leg movement. Periodic leg movement accompanies restless leg syndrome in many cases. What is periodic leg movement? It is basically dorsiflexion. There is jhatka, dorsiflexion of the foot, 0.5 seconds to about 3-4 seconds, and this occurs repeatedly through the night. That might actually disturb the partner and sometimes even wake the patient up. So periodic leg movement should be one symptom that you should be looking for. So once you think of restless leg syndrome based on these symptoms, the first thing to learn is that we have to decide whether it is a primary or a secondary restless leg syndrome. Primary means idiopathic. Idiopathic restless syndrome is due to dopamine deficiency. Secondary restless leg syndrome, is due to other etiologies. The commonest, most important, and correctable etiology is iron deficiency. And there are other causes like pregnancy, CKD, etc. But most importantly, iron deficiency must be ruled out. So any restless leg syndrome patient, you will do the routine workup, creatinine, electrolytes, calcium, etc. But you will do iron studies. Ferritin is, as you know, the most sensitive test for iron deficiency. However, ferritin can be falsely high in acute situations like even a URTI. So you might have to do a serum iron study where serum iron levels are low and transferrin saturation is low. So once you diagnose iron deficiency in a patient whose clinical features are like RLS, the treatment is with iron. Parenteral iron is not supposed to be superior to oral iron. So give oral iron to all these patients. Give 50 milligrams or 25 milligrams, whichever you chose, but don't give 100 milligrams. 100 milligram preparations like Ortrin or Oro for XT, etc. The high dose preparations are not needed. 50 milligrams is what you can give maximum. And if you give 50 milligram iron with vitamin C, at least 250 milligram, maybe 500 milligram, the patient's symptoms will ameliorate fairly rapidly. So do that first so that the patient gets better. Is restless leg syndrome commoner in menstruating females because they have iron deficiency? No. Restless leg syndrome, if it is familial, is commoner at a younger age. But typically, restless leg syndrome starts after the age of 40, and onset is between the age of 40 and 50. Familial restless leg syndrome is approximately 50% of all cases. So it's an important thing to ask history while diagnosing whether anybody else in the family has this kind of a problem. If the restless leg RLS is not due to iron deficiency and there is no pregnancy, no CKD, then you have to think of primary or idiopathic restless leg syndrome, which is supposed to be due to dopamine deficiency. These patients are treated with either dopaminergic drugs or gabapentinoids. Dopaminergic drugs typically used are pramipexole and ropinirole, whereas gabapentinoids typically used are pregabalin or gabapentin. So you have to use between these two. Till now, or even now, the principal first choice drugs amongst most neurologists has been pramipexole or ropinirole, which are drugs, as you know, are dopamine agonists, or also they are anti-Parkinsonian drugs. Dopamine agonists are commonly are used as first choice in most situations in India, at least. However, the US now recommends, the societies or neurology societies now recommend that gabapentinoids may be a better first choice treatment for restless leg syndrome, simply because there are of two side effects of the dopamine agonists. What are these two side effects? The first side effect that is important is augmentation. Augmentation, as the word suggests, is increase in the symptoms of RLS. It is seen that due to the dopamine agonists, after a certain duration, a few months maybe, the patient worsens. And this is worsening is not due to the progression of the disease, but due to the drugs. And when the patient worsens, our natural tendency is to increase the dose of pramipexole. This will make it even worse. So what has to be done is stop the drug or taper the drug to a lower dose and see whether the patient improves on lowering the dose rather than increase the dose. And this is called augmentation. And often augmentation will make you switch from dopamine agonists to gabapentinoids. What is the typical starting dose of dopamine agonists? 0.25 milligrams of pramipexole, and to be increased to a maximum, I think, what would be 0.75 milligrams of pramipexole, usually given as a single dose in the evening. What is the second side effect of dopamine agonists which can cause trouble? The second side effect is impulse control disorder. Impulse control disorder is basically something that can happen in, say, bipolar illness, where the patient goes into the manic phase. He can have excessive gambling, excessive desire for sex, excessive trading in the stock market, excessive purchasing or shopping. This is called impulse control disorder. This is a side effect of dopamine agonists. This impulse control disorder is more commonly seen in Parkinsonism being treated with levodopa, carbidopa, or with other dopamine agonists, and less in restless leg
Hello,
syndrome.
Tushar
But
sir.
this is when,
हेलो तुषार सर
yeah, Himali,
सर आप कर सकते हो पीपीटी
I can't hear you, Himali. Can you speak a little loudly?
हेलो
हाँ जी,
सर आप अपनी स्क्रीन शेयर कर सकते हो
मुझे है ना थोड़ा सा टेक्नोलॉजिकल चैलेंजेस हैं, तो मुझे स्क्रीन शेयरिंग कैसे करना मैं देख रहा हूँ. मोर में जाऊँ?
नहीं
आप
at the
share
back
का
there is a share screen option at the back of this screen only. There is a green color का बटन है share screen.
Got it. एंड क्या करूँ उसमें? माइक्रोसॉफ्ट
और-
वन ड्राइव, शेयर पॉइंट, गूगल ड्राइव वगैरह दिया है.
नहीं, और आपकी जो पीपीटी है सर उसको सिलेक्ट कर लीजिए आप, उसको ओपन करके.
पीपीटी तो डॉक्यूमेंट में होगा, पीपीटी है नहीं इधर.
हाँ, ओके, कोई बात नहीं सर, कंटिन्यू जस्ट फॉर द नेक्स्ट टाइम यू जस्ट शेयर योर स्क्रीन
एक
स्लाइड.
मिनट, हिमाली टेल मी.
यस सर आपके पीपीटी आपने ओपन किया है पहले सिस्टम में
नहीं, सिस्टम में पीपीटी कैसे ओपन करूं? मेरे मतलब जहाँ पे आपने शेयर किया था व्हाट्सएप पे, उसमें जाऊं?
हाँ तो आप डाउनलोड कर दीजिए पहले उसको और वहां पे आप डबल क्लिक कीजिए तो पीपीटी ओपन होगा.
Okay, let me see
सिस्टम में ओपन.
while I will do it once I finish my preliminary talk, and then maybe I will go there. So yeah, we were talking about the second side of it, impulse control disorder, which is not seen in gabapentinoids. So now the second group of drugs is gabapentinoids. Gabapentinoids is a a longer name for this group, which we shall ignore. But the two important drugs that are available easily in India are gabapentin and pregabalin. These also work for restless leg syndrome. They do not have those two side effects of impulse control disorder and of augmentation. However, as you know, pregabalin and gabapentin have their own side effects, principally being drowsiness, dizziness, tendency to fall, especially in the elderly, occasionally weight gain, occasionally GI disturbance. So gabapentinoids are not without side effects also. Now, if you want to use gabapentinoids as a first line or as a second line, then I typically advise that you start with gabapin, that is gabapentin 100 milligrams only at bedtime, and rapidly increase, say every 3 days or 4 days, to 300 to 400 milligrams per day. Never combine it with, say, nortriptyline or amitriptyline. Nortriptyline and amitriptyline not approved for use currently in restless leg syndrome. So use gabapentinoids in this fashion. Many people prefer pregabalin. Neurologists especially prefer pregabalin over gabapentin. So if you want to use, say, 75 milligram pregabalin, remember that 75 milligram pregabalin is equal to about 300 to 450 milligram of gabapentin. So start low with gabapentin. Once you reach 300 milligram gabapentin, maybe you can switch to pregabalin. Some people like the Pfizer brand very much. Then you can use that, which is expensive, 60 rupees a tablet of Lyrica. But you can use 75 milligram and go up to maximum of 150 milligram of maybe pregabalin. How long do you give the treatment? Remember, a restless leg syndrome of the idiopathic variety is a lifelong ailment, and the treatment is lifelong. There is no natural history where the disease goes away. So what can be done is you can toggle with the doses so that you can go up and down the dose. The patients often will themselves stop the medicine and they will feel good for a month or so, and then they'll come back with the symptoms. But you must educate them that this disease is lifelong, and you have to take medicines like blood pressure medicines. You have to take these medicines also lifelong. So that is about restless leg syndrome. There are some devices available in the West for compression of the legs in the night. I don't know if there is any such device available in India. This is for patients who do not tolerate the medicines. The second topic that we take, I'll take questions on each of these after we finish my primary talk. The second disease that we discuss now is essential tremor, a very common outpatient neurological disorder. Essential tremor. Essential, the word says it's idiopathic. When we say idiopathic, many cases, maybe more than 50% of cases, are familial. So it runs in the families, and you must ask history of family, even in essential tremor, like you did in RLS. How does an essential tremor present? Typically, the essential tremor presents at a young age, even sometimes in early childhood, if there's a genetic predisposition. Otherwise, in a non-genetic predisposition like RLS, it presents after the age of 40. Essential tremor principally is an action tremor. What is an action tremor? There are three kinds of principal kinds of tremors. One is action tremor, also known as postural tremor. Action tremor is basically when the patient is asked to keep the limb. You can see my hand. It moves when it is outstretched and kept in a steady posture. That's what it's called, postural or action tremor. It affects all limbs. It can affect the trunk. It can affect the head, which is called titubation. It can affect the voice, which can be quite bad for patients who speak, teach, sing, etc. So these are the various tremors. Important thing about this is that it is not a resting tremor. It is a tremor on action, except the head tremor, which can be a resting tremor. So many people mistake essential tremor with Parkinsonian tremor. Remember, Parkinsonian tremor is a resting tremor. Patient's hand is resting and still it moves like this with a pill rolling, flexion extension at the wrist, metacarpal. This is a resting tremor and not an action tremor. Having said that, in Parkinsonism, occasionally you can get an action tremor like this, but that's a secondary minor tremor. The major tremor is resting tremor in Parkinsonism. So it's not difficult to differentiate between the two. And one important clinical feature of essential tremor is that it subsides with alcohol. So it's an interesting thing. Can we use alcohol as a therapy? You can actually only in one situation. If the patient has an important social engagement, like a meeting, etc., you may ask him to take either propranolol or alcohol before going to the meeting. But interestingly, propranolol works better than alcohol, unfortunately, at least. So now when we have diagnosed essential tremor as the condition, what is the next step? There is no diagnostic test for essential tremor. Maybe you can give alcohol and see whether it improves, but there's no other diagnostic test. You can make the patient draw a spiral. I'll show you a diagram of that. Essential tremor has a very peculiar spiral, and Parkinsonism has basically micrographia. So the handwriting also differs in both these conditions. So you can make them do that spiral and see whether there's a tremulousness in the line that he draws. Once you diagnose essential tremor, do you treat it always? The first important thing to ask the patient is, does the essential tremor bother you? If the patient is young and has to write exams and says, I can't write my exams because of the tremor, you treat. If the patient says, I'm okay, only occasionally while signing my name, there might be some trouble, but otherwise I'm fairly okay with my tremor. I don't have problem eating food, etc. In which case, don't treat till the need arises. So essential tremor will be treated if the patient wants treatment. If the patient has significant tremor, you have multiple choices of medications. What are the choices that we have in essential tremor? The most commonly used drug group is beta blocker. And within the beta blockers, the most commonly used drug is propranolol. Propranolol, we will start with whatever dose, like 10 milligram BD1, because young patients with essential tremor may have a baseline blood pressure of 100/70, for example. So you will start often low and then go higher. As the PP tolerates or the bradycardia does not occur, you can increase the dose. Typically, 40 milligram BD is all that is required. Can we use other beta blockers like nebivolol, carvedilol, etc., or even metoprolol? We can. Metoprolol, probably we can. But I would say if the patient is hypertensive and is already on metoprolol and has an essential tremor, you will often have to switch to from metoprolol to propranolol for a better control of essential tremor. If the patient is asthmatic, has significant COPD, and you cannot give any beta blocker, remember, amongst beta blockers, it is often said that we have uh, uh, cardioselective beta blockers, which will not worsen asthma or COPD. I think that is at least partly a myth. All beta blockers will have some activity, some aggravation of bronchospasm. So I would say if the patient has significant asthma or COPD, avoid beta blockers and use other drug groups. Which other drug groups can you use? Most neurologists now prefer primidone as the second choice. Primidone is a barbiturate, and this barbiturate in epilepsy is used in high doses, 250 milligram, etc. In essential tremor, start with 25 milligrams of primidone once a day, and may increase up to 50, 100, or 150 also. But that is not, the dose is not as high as in epilepsy. Barbiturates have their side effects like drowsiness, but this is a low dose barbiturate, so it's fairly well tolerated. If a patient does not tolerate barbiturate because of drowsiness, does not tolerate beta blockers, now we have a third choice in the form of topiramate. Topiramate is a drug that we know is used in epilepsy, is used in migraine prevention. Now it is also used in essential tremor. Topiramate typically started as 25 milligram at bedtime and then in the morning typically, and then can be increased to 75 milligram. The fourth drug is clonazepam. Clonazepam is, as you know, an anxiolytic drug and also an habituating drug. So clonazepam is not a popular first choice, but can be used to suppress the tremor. What is the, there are many combinations available in the market of propranolol with clonazepam. I would strongly advise against using combinations, also because clonazepam patient gets used to and then does not stop. And it being a benzodiazepine, we can have addictive properties and maybe some cognitive dysfunction in the long run. Another choice that we have amongst drugs is Botox. Now, voice tremor, unfortunately, does not respond to these drugs. So, if the patient has a voice tremor and has to teach, has to speak, you have a choice of giving Botox in the vocal cords. The problem with giving Botox there is in the larynx is that the patient's voice may turn hoarse. And for example, a singer doesn't want a hoarse voice. So it's a slightly tough situation for singers, especially. There are other treatment modalities for essential tremor, but which are more advanced, and I will probably skip those. The third disease that we discussed today is acute migraine. All of you are familiar with acute migraine. I don't have to kind of elaborate much on this, but I'll give you certain suggestions which might be useful. A recent study has come which says that the three best headache, sorry, I'm so sorry, but essential tremor, I forgot to tell you that again, the essential tremor is not curable and the treatment is lifelong. If needed, it is lifelong. Okay, so now about acute attack of migraine. Acute attack of migraine, we all use multiple drugs from paracetamol, NSAIDs, opioids, triptans, etc. When you have an acute attack of migraine, the most important thing to remember is that triptan use has to increase at the family physician level. We have a little unfamiliarity with triptans. Neurologists use it very commonly. We don't. And that might have to change. The reason is triptans are probably the most effective headache suppressor if used early in the disease and if used in an appropriate patient. Why appropriate patient? Triptans are vasoconstrictors. So triptans are contraindicated in several situations: pregnancy, atherosclerotic cardiovascular disease, two very important areas where triptans are avoided completely. So if you're using a triptan in a correct situation, you have to remember you can't use it late. If you start triptan maybe 2, 3, 4 hours after the onset of headache, they won't work. Also, you can't use triptans during aura if there is patients have migraine with aura. So triptans will be worsening the aura because triptans are vasoconstrictors. And aura, one of the pathophysiology of auras is vasoconstriction. So triptans, if correctly used, are good drugs. And which triptan should you use? The fastest acting triptan is supposed to be rizatriptan. Rizatriptan comes in 5 and 10 milligram tablets or in 5 milligram mouth dissolving strips, which you keep on the tongue. Rizatriptan, more expensive than other pain medicines, but maybe a good choice if you want to start with rizatriptans. The other triptan, which may be acting faster than sumatriptan, for example, is a nasal spray of zolmitriptan. Zolmitriptan nasal spray comes in a bottle which delivers 5 milligrams per spray, which is the dose. So you can use zolmitriptan, especially if the patient is nauseous, vomiting, and oral tablets may not be tolerated. Then zolmitriptan might be a choice. Sumatriptan is also a choice. I would prefer rizatriptan over sumatriptan. In severe headache, in patients who do not get better with, say, rizatriptan or a single NSAID, then the combination of naproxen and sumatriptan is available, and you can use 500 milligram naproxen plus 85 milligram sumatriptan tablets to early in the headache and give treatment. So these are triptans. I am again reiterating that triptan use should increase. The other group that is supposed to be effective is ergots. Ergots, as you know, are again vasoconstrictors, and ergots again are not to be used in pregnant women, even if there are childbearing age women who may have pregnancy which you don't know about. Avoid both triptans and ergots. Ergots cannot be used in atherosclerotic cardiovascular disease. So ergots have to be again used with the same caution. In ergots, one important thing is that plain ergot I don't think is available, so we'll have to use combinations. So we have ergot with caffeine, typically Migranil EC is a brand name, for example, or ergot with caffeine, with paracetamol, with prochlorperazine, what we call, say, Vasograin as a brand name. So we have several preparations of ergot available. The correct dose of ergot is 1 milligram, and the correct dose of caffeine is 100 milligram. So you can use a combination like Migranil EC, which does not have paracetamol, but the correct doses of these two drugs. Remember, Vasograin may have the correct dose of ergot and caffeine, but does not have the correct dose of either Stemetil or paracetamol. So use Migranil EC-like drug, and then if you want to give Stemetil, use separately Stemetil. So and paracetamol. So this is ergot. The third most effective drug group is antiemetics, surprisingly. So we have the most effective drug group and triptan in ergots and in antiemetics. Antiemetics, as you know, there is metoclopramide, that is Perinom, and prochlorperazide, which is Stemetil. Now, Stemetil and Perinom are sometimes even effective alone, if especially given injectable. You can give Stemetil intramuscular or Perinom intramuscular and or IV, and in an acute attack where vomiting is a predominant symptom. So, what? How will you use Stemetil Perinom? You would probably use them in combination: paracetamol with Perinom, paracetamol with Stemetil. Domperidone is also used by many in combination with paracetamol. Domperidone is not approved in the US, and hence it doesn't come into the literature so much. So antiemetics are an important component, especially in patients who have nausea or are vomiting. The other important group of drugs is NSAIDs. NSAIDs are, we know that the most approved anti-inflammatory drugs are indomethacin and naproxen. So use any one of the two if you have to use an NSAID. Some people use aspirin, that is Dispirin, which is fine. Saridon, if you have heard the brand name Saridon, many patients themselves use. And Saridon also has an NSAID. Some preparations of Saridon have an NSAID with paracetamol. So Saridon, you should use carefully, or at least tell the patient not to use Saridon at all if they have cardiovascular disease or renal disease, because there is an NSAID there. So we have NSAIDs as another group which can cure the headache. If the headache is extremely severe, or the patient has what is called a status migrainosus, severe headache, then you may have to use parenteral drugs like opioids parenterally, like tramadol, for example. And you may have to use steroids, because steroids are also useful in severe migraine, which is not resolving. So these are the options in treating acute migraine. Having said that, I should discuss also how do you diagnose migraine, because the most important thing about migraine is that one, not all headaches are migraine. Secondly, migraine is correctly diagnosed very often, but incorrectly diagnosed also fairly often, meaning the patient has some other disease like temporal arteritis, like subarachnoid hemorrhage, and then patient is thought of as migraine. So there are criteria for diagnosing migraine. Once I show you the slides, I'll come back to the criteria. But there should be at least 2 or 4 major criteria and 1 of 2 minor criteria. The minor criteria are photophobia, phonophobia as 1, and nausea, vomiting as 2. At least one of the 2 should be present if you want to diagnose migraine. This is, I'm talking about migraine without aura. If aura are there, then migraine is easier to diagnose without strict criteria. If and what are the 4 major criteria? 4 major criteria is unilaterality, meaning one-sided headache, throbbing headache, headache that disturbs the daily activities, and headache that worsens on movement, like climbing stairs, like walking. 4 major criteria, of which 2 should be present. I'll say again: unilaterality, throbbing, worsening on movement, and disturbing the daily activity. So if you have 2 of these and 1 of the photophobia, phonophobia, nausea, vomiting, then you have diagnosed migraine. Only if there are multiple episodes in the last few months. So there are some criteria layout. Some criteria say there should be at least 5 episodes of sub in 3 months. So once you have diagnosed migraine, then of course you will give the acute medicine. One more thing about acute medicine is do ask the patient what relieves him or her. Many patients, because they've already been diagnosed as migraine, when they come to you, they will say, I get better just with one paracetamol 500 milligrams. I don't need anything else. Respect that choice of the patient. Don't say, okay, now you must not take paracetamol because I believe triptans are better. No, the patient says the patient's truth is paramount, and you have to respect that. So once you have kind of explained the options to the patient about acute treatment, the next decision that you will have to make in migraine is whether I give prophylactic therapy or not. Now, this is one area where there's severe undertreatment in migraine. All migraine patients know about acute medicines. What can they take? But most of them are not even aware that prophylaxis is possible. Doctors do not give prevention. They keep on giving SOS or as needed medicines. We have to improve there. We have to give preventives in deserving patients. Now, which patient deserves daily prophylactic therapy for months together? Now, you have to ask the patient this. Now, there are criteria again, 4 attacks per month lasting 4 hours at least each time. There are many criteria, but I think those criteria are useless. You have to ask the patient, I have a choice of giving you, prescribing for you medicines which will not cause a headache, which will prevent a headache. Now, if the patient gets one headache per month, which debilitates the patient for 2 days at a time, and the patient has a small kid at home with no other support system, the patient will say, no, you give me preventive. I can't afford even 2 days of headache. So don't go by criteria, go by the patient's need. Now, if the patient needs prophylaxis, you have many choices for prophylaxis. The most important three drugs in prophylaxis of migraine are beta blockers, topiramate, and valproate. Beta blockers, as you know, again, propranolol is the number one beta blocker in migraine prevention, and metoprolol is also used. The second drug is topiramate. Again, we discussed it in essential tremor, so that's a common indication. And the third drug is disodium valproate, uh, or you can even use valproic acid, but disodium valproate is the commonest used molecule. These three are the primary drugs used for prevention of migraine. Now, which will you choose? If the patient is a childbearing age group patient, because many migraine patients are young females, then you will be very careful about not using valproate, because valproate is a teratogenic drug, extremely important. Also, valproate causes weight gain, valproate causes hair loss. So, young females would not prefer valproate. But having said that, valproate is a very effective prevention drug. So, you will probably use a beta blocker in such patients. So, beta blockers, if you are using, many young females have baseline BP of 90 by 60. So you might have to be careful. I don't hesitate in starting, even in 90 by 60, 10 milligram BD of propranolol. Start it. See the patient, and if often the BP remains at that level, 90 by 60, and increase it to 20 milligram BD. See whether the patient can tolerate that dose. And once you reach a dose which the patient tolerates and you cannot go beyond that, and the patient's attacks are not lesser, you may have to add another drug. What do these drugs do? They reduce the number of attacks per month or per quarter. So they often do not banish the attacks. The attacks may keep coming. So you have to educate the patient that okay, you will still get headaches, but they will be milder and they'll be less frequent and of a lesser duration. Beta blockers are one drug. The other drug is topiramate. If patient is asthmatic, cannot be given beta blockers. Again, you use topiramate. Topiramate has one advantage in that it may cause a little weight loss, so at least does not cause weight gain. And topiramate has some side effects which are very peculiar to topiramate. Often, within 1 or 2 doses of topiramate, patient will get paresthesias, tingling in the around the lips, limbs, etc. And you will have to stop the drug. So warn the patient that okay, if paresthesias occur, we will stop the drug. Another side effect is kidney stones. If the patient already has kidney stones, I would avoid topiramate. The third side effect is a little cognitive disability of forgetting names. Uh, so this naming aphasia, we may call it, this a very peculiar side effect. The patient will say, okay, I can't now recall names of my relatives or brand names of drugs if I'm a doctor, etc. So this is a reversible side effect. You have to stop the drug. Again, start with 25 milligram and can go up to 75 milligram probably. The other drug is, as we said, is valproate, disodium valproate, which is 250 milligram to begin with once a day at bedtime, and can go up to 500 maybe 750 milligram. Usually 500 is enough. Once you start a primary prophylaxis treatment, usually give it for 3 months and then try to taper it. Sometimes the patient will have what we can call a remission for several months or years, and then can get a recurrence of the frequency, and then you can restart the drug. As you know, migraines natural history is that many patients outgrow migraine. You don't have lifetime migraine in most patients. So you hope that the disease itself goes away. You do know that these drugs or primary prophylaxis do not alter the natural history. They will not cause a remission by themselves. The disease will remit, and you may be able to withdraw the drug. There are other drugs to use in migraine, and we use them even more commonly sometimes. And one of them is, for example, flunarizine. Flunarizine Sibelium is a popular brand name. Flunil is a popular brand name. Flunarizine is a drug which is not a very good drug in reducing frequency of attacks, but some patients like it. The problem with flunarizine is, again, it can cause weight gain and it can cause drowsiness. So young females who are studying, for example, they may not like flunarizine very much. In the older person, flunarizine has two distinct side effects. One is it causes depression if used for several months together. So remember never to use flunarizine for more than 3-4 months. And if you stop flunarizine, you will see that the effect of flunarizine lasts for several more weeks, even after stoppage. And then you may want to restart it if necessary. But otherwise, depression is a problem with flunarizine. And another problem with flunarizine is Parkinsonism, drug-induced Parkinsonism. As you know, cinnarizine, which is the related drugs to Geron, for example, and flunarizine can cause drug-induced Parkinsonism. So try to not give it for a prolonged period if you use. Another drug that is used often is amitriptyline or nortriptyline. Again, tricyclic antidepressants may be useful, especially in patients who have a slight affective disorder. It is said that many migraine patients also have depression along with migraine. So you may be benefited by a small dose, but the dose here is not the depression dose. The dose here is 10 milligram to begin with, maybe 5 milligram. I usually start with 5 milligram, break the 10 milligram tablet, and take 5 milligram, and increase it maybe up to a maximum of 50 milligram. It's a good drug in prevention, and side effects, as you know, are weight gain sometimes anticholinergic side effects like dry mouth, constipation. But the doses are low, so the side effects are less. Nortriptyline is an alternative to amitriptyline, especially in the older patient where dryness of mouth, etc., are a little less with nortriptyline than with amitriptyline. These are TCAs. Then there is cyproheptadine. Cyproheptadine is a drug which is also used as an appetite stimulant in children, especially. It is a preventive drug. In which patient will you use cyproheptadine? Maybe in patients who have low appetite, are underweight, because it also causes weight gain. That can be used 2 milligram, 4 milligram at bedtime. So these are some options in prophylaxis of migraine. There are newer drugs called calcitonin gene receptor peptides. These are monoclonal antibodies, CGRP monoclonal antibodies, which have come, injectable drugs, and I will not discuss them because they're not outpatient drugs really. And if the patient start developing what is called as chronic migraine, which is defined as 15 days of headache per month, then you must refer the patient to a specialist. You should not keep the patient with you once chronic migraine occurs. Also, one condition is MOH, medication overuse headache. In migraine, often the patient will keep popping naproxen or other pills, and if they if they use it very frequently, say 15 days a month, they may develop actually a rebound worsening of headaches called MOH. And such patients again will have to be referred to a neurologist so that better care can be taken. So this is about acute treatment of migraine and prophylaxis of migraine. This was my next topic. One more topic that Dr. Pragnesh has been asking me to talk about is red flags in headache. A patient comes to you with severe headache and You diagnose migraine, give naproxen, the diagnosis is incorrect and the patient has a subarachnoid hemorrhage. How do you decide what are the red flags in a patient with headache? If a patient comes with an acute headache, which is a first time headache, which is a headache that she's never experienced the intensity of before, you must think of subarachnoid hemorrhage, young or old. Subarachnoid hemorrhage are often traumatic, but if there's no history of trauma, it is due to a rupture of a berry aneurysm. So if a patient comes with what they call a thunderclap headache in literature, a sudden flash of headache, which is severe, which can be throbbing or which can be severe constant headache, and the patient sometimes have mental obtundation, mild drowsiness, vomiting, you must think of subarachnoid hemorrhage. The best thing to do is send the patient to a tertiary center where they will do a DSA or similar investigation and maybe put a coil in the aneurysm, etc., or clip the aneurysm. So you must diagnose diagnosing subarachnoid hemorrhage is saving a life. That is very, very important, and one must not miss a subarachnoid hemorrhage. So the red flag here would be first time headache, intensity like never before headache, vomiting, mental obtundation. This is Then there is another thing called chronic subdural hematoma, which happens in the elderly. Chronic subdural hematoma again comes sometimes with flimsy trauma to the head, meaning patient may not even remember the head injury. They are in the bathroom, they slip a bit, bang the head against the wall, and that injury may have occurred 3-4 months ago. And this patient therefore has no remembrance or no memory of that injury. And this elderly patient, because they are elderly, they have a problem with the dura being a little away from the skull, and a jerk can rupture the vessel around the dura, and this causes a subdural hematoma. And this subdural hematoma will gradually increase in size and then cause symptoms. And very, very non-focal symptoms can also appear, meaning the patient will have some weakness, some slurring of speech, no frank hemiplegia. Patient will have some mental obtundation, memory problems. So relatives will notice that there is something wrong with the patient, and you might diagnose Alzheimer's, you might diagnose depression, but the patient will have some headache maybe, and you will have to do a CT scan to find that there is a subdural hematoma, which can be easily treated. In fact, bilateral chronic subdural hematomas are called a correctable form of dementia. So this is one more disease that you should not miss. Another neurological disorder that you should not miss is metabolic encephalopathy. As a family physician, we know that many of our patients are on thiazides, hydrochlorothiazide or chlorthalidone, and some patients are on antidepressants, which can cause hyponatremia. All these drugs, antidepressants, sometimes oxcarbazepine, sometimes mirtazapine, or thiazides, can cause hyponatremia. In the elderly, if such drugs are going on, and especially in doses that are not really great doses, like 12.5 milligram chlorthalidone is not a good dose to give. You have to restrict yourself to 6.25 milligram in the elderly. If these patients are come to you, or the relatives call up and say that the patient is drowsy, dull, not talking,
Sir, you are muted, sir.
you do a sugar level and the sugar is normal, is not hypoglycemic, then the first thought that you must think of is hyponatremia. General mild mental obtundation or stupor, you must think of hyponatremia. Again, an easily correctable problem, but patient has to be hospitalized. Don't start drips at home. You can't do that. You have to hospitalize the patient. Find the cause of the hyponatremia. It may be dehydration, it may be diuretics, it may be many other conditions. So hyponatremia is another easily diagnosable condition which is often missed. Another neurological problem that you can prevent is Wernicke-Korsakoff psychosis. Wernicke-Korsakoff psychosis, as you know, are two distinct but related problems. Wernicke's encephalopathy is mental obtundation, ataxia, sometimes extraocular muscle weakness, and Wernicke's encephalopathy occurs typically due to thiamine deficiency, and thiamine deficiency usually is present in alcoholics. And if an alcoholic for some reason gets hypoglycemia and goes to the hospital in a mentally obtunded state and they give IV glucose, then the patient will go into encephalopathy very fast if thiamine was not given to the patient simultaneously. Our job as a family physician is that we must, any patient with mental obtundation, irrespective of whether we know the cause or do not know the cause, as a family physician, when you go to the residence or they come to a clinic, give them 100 milligram thiamine intramuscular. The patient may be an alcoholic, may not be an alcoholic, may have thiamine deficiency, may not have, but giving thiamine is not a problem. We all know that thiamine is one vitamin which can cause anaphylaxis, but don't worry about that. Give thiamine 100 milligram intramuscular and send the patient to the hospital. That might prevent this Wernicke-Korsakoff syndrome. Korsakoff psychosis, of course, is something that follows Wernicke's encephalopathy and is a form of psychosis, hallucinations, etc. Now this is one more disease that we would like to prevent. Yeah, I think I have come to the close of my session in terms of my talk. I'll just look for my PPT. My PPT is here. Okay. So my PPT is with me. Is someone there from the team?
Rochelle?
Open your
Rochelle,
PPT.
Emali, anybody? I can open the PPT. I don't know how to download it. If there's any way to know how to download the PPT.
Right click करो तो कदा download no option આવશે.
Okay. Meanwhile, I'll download PPT in a moment. It's not very important that we have the PPT, but if I can ask the audience to start asking questions, and maybe I can. So we are taking a question through YouTube, right? Or even the panel sitting here, if they have questions, Dr. Preeti or Dr. Vibhagar.
Dr. Preeti, you would be knowing, I think.
Yes, we have to go to the YouTube version. I've joined from my mobile. I will not be able to join from another.
Is Himali able to do it?
So I have a question, sir.
Yeah, sure.
So restless leg syndrome, people have burning feet, but they do not have abnormal movements.
Correct.
So treat that with gabapentin if it is intolerable, or there is any other option.
So burning feet syndrome is a very specific condition where the patient complains of jalan in the soles of feet. And this condition is often due to deficiency of pantothenic acid. I would strongly recommend that any patient who has the sole symptom of burning in the soles, that is the only symptom. If that is the only symptom, then please do not give drugs like amitriptyline, gabapentin. Just give a high dose of 500 milligram BD, pantothenic acid, which is very, very effective in treating burning feet syndrome. Pantothenic acid in this dose is not available in regular pharmacies, but if you ask the patient to go on Amazon or some Flipkart or similar site, or even an online pharmacy, you will get this drug without much difficulty, but the dose has to be correct. Pantothenic acid, 500 milligram twice a day. Again, burning feet syndrome is a problem which may demand regular doses for a long, long time. What I typically do is give the dose, patient miraculously improves, and the patient stops the medicine, they get the problem again. So I tell the patient, you must take it for months together and then see whether you can do with one tablet of 500 milligram or lesser. But it's a good diagnosis to make. There is no, I don't think I've ever done blood test for pantothenic acid, though it is available. I would just give a therapeutic trial.
Sir, should this burning feet only be in the sole, or if it is in the dorsum also, it comes handy?
No, burning feet classically is described as sole, not dorsum. So dorsum and plantar both being affected bilaterally, probably more like sensory neuropathy of diabetes or some such similar disease. Somebody can go on YouTube and see whether they can find. Sorry,
Bali,
just a second. Somebody from the tech team. Roshil, are you on YouTube? Okay.
Dr. Pragnesh has gone, I think. Dr. Preeti, can you?
I will just see if I have a link to the YouTube. Okay, I was not sent the link to YouTube. I was sent the link to. Oh, actually, I might have been. I was sent.
So I'm on YouTube, sir.
Yeah.
Okay.
Do you
So I'll
have any
just read the
questions?
questions.
Please.
Yeah, what is the latest treatment for Parkinson's?
Okay, so I did not discuss Alzheimer's or Parkinson's deliberately because those are two diseases that I would say the family physician should leave to the neurologist. What you should do with Parkinsonism and with Alzheimer's is you should know the side effect of drugs, and these side effects are the ones that we will have to manage as the family physicians. Having said that, first of all, your question as to what is done in Parkinsonism. I'm not an expert on Parkinsonism. I will first claim that. But the drugs, the standard dopamine agonists, which are pramipexole, ropinirole, are often started as the first line drug in Parkinsonism, not levodopa carbidopa, especially in the early stages, so that they spare the levodopa carbidopa for a more severe disease. So in mild disease, typically that is started. Sometimes MAO inhibitors like selegiline is started, razagiline and selegiline, as you know, are sometimes started. But again, I'm not sure about the doses, etc. So I would not go into that. Then we have, of course, levodopa. Levodopa is invariably combined with carbidopa. And now there is a combination of three drugs available: levodopa, carbidopa, and ardipine. Ardipine reduces the peripheral metabolism of levodopa and allows about 30% more levodopa to go into the brain. So this is available now. What is important here for the family physician is to recognize side effects. When you start a patient on levodopa or syndopa, most patients will first develop GI symptoms at the smaller doses. So remember that initially, if they take the tablets on empty stomach, which is the recommendation because food retards the absorption of levodopa, then they will have significant gastritis, and the patient will say, I don't want this medicine. Initially, you start the medicine on medicines with meals. Even if the neurologist has said, okay, take it on empty stomach, you tell the patient, first few days we will take with meals, and if you tolerate the medicine, we will start taking it on empty stomach. So this is one important message that you must give. Second important message to give is to the patient is don't give it with a heavy, high protein meal, because high protein meal reduces the absorption of the syndopa. So that is one thing that the GP can take care of. As the patient's disease advances or as the doses increase, there are two problems that occur. One problem is called the on-off phenomenon, or the efficacy of syndopa, levodopa, etc. Fluctuates. This fluctuating motor phenomena you should be able to recognize and therefore talk to the neurologist about that. Meaning the patient will have some days the patient say, my syndopa gives me effect for 2-3 hours, and some days it will not have any effect at all. The tablet that I have taken will not have any. So these on-off phenomena can be managed by manipulation of doses, which the neurologist can do. Second motor phenomena are, of course, the dyskinesias that the patient develops because of syndopa or such dopamine agonists. So these are patients who will have disorders like writhing movements of the hands or of the head, and they'll have uncomfortable movements, like you feel that they are dancing to some music, and the patient does not mind these problems often because they're active. They're very active in these dyskinesias. But again, this is something that you will have to refer to the neurologist and get corrected.
So there's a question on role of vitamin E in restless leg syndrome.
Okay, so supplements have no role in restless leg syndrome. You have to check the vitamin D levels and correct the vitamin D levels. But magnesium or vitamin E or zinc have no role in restless leg syndrome. So often we make the mistake of giving vitamin E for prolonged periods, and there is absolutely zero role. And in fact, vitamin E given for prolonged periods can cause cause problem. So vitamin E can cause increased.
फोटोज है बट कलर में नहीं है ब्लैक
Dr. Preeti,
Yes,
you
sir.
might have to mute.
Yes,
mute
sir.
it. Sorry.
Sorry,
So,
sir. Sorry.
no problem, no problem. So vitamin E can increase chances of intracranial bleeds if given for a long time. It can increase chances of cancer, prostate cancer, for example, if given for a very long time. So beyond 2 years, never give vitamin E. I don't give beyond 1 year vitamin E for any indication. And most indications now are not valid for vitamin E. So definitely not for restless leg syndrome. Having said that, for migraine, there are some views that magnesium supplementation may be useful for migraine. So that is something that you may give empirically, especially pregnant patients with migraine. If you want to give prophylaxis and you can't give any other drug, you can supplement magnesium. Yeah. Dr.
Sir,
Preeti.
can you explain? Sir, can you
Anil.
explain certain neurological causes of vertigo?
Dr. Sanjay, thank you for the question. Neurological causes of vertigo. Okay. So vertigo, as you know, there are two types of vertigo, central and peripheral. Peripheral vertigo is related to the inner ear. The commonest form is BPPV. Another common form is vestibular neuronitis. And the third common form is Meniere's disease. These are peripheral causes. Central causes of vertigo, the most mistaken thing is that many patients believe that cervical spondylosis with osteophytes pressing on some artery, vertebral artery or something can cause vertigo. They cannot. Cervical spondylosis does not cause true vertigo. So vertigo is due to, if it is central, it is due to brainstem disorder. And that brainstem disorder can be brainstem ischemia, meaning vertebrobasilar disease, atherosclerotic disease, or it can be due to any pathology in the brainstem. So like a tumor, for example, or an infarct or a hemorrhage. That can cause vertigo, but multiple sclerosis in the brainstem can cause vertigo, but not cervical spondylosis. Yes, sir. Sorry, Dr. Preeti, you might want to unmute.
Yeah. So the differential diagnosis, how do you differentiate between vertigo and migraine? That's a question on YouTube.
That's an excellent question because I should have covered that area. There are many variants of migraine, and one of the variants of migraine is vertiginous migraine or migraine with vertigo overlap. So many patients will come with recurrent episodes of vertigo, which you think are vertigo, and often these vertigo episodes are associated with vomiting each time or some headache. And these patients you should consider giving migraine prophylaxis because often these patients will turn out to be a variant migraine rather than. So there are two types of variant migraines that you should be on a watch out for. One is the migraine with abdominal symptoms, where patient has comes with recurrent recurrent vomiting without much headache, and one is with vertigo, recurrent vertigo. So if you send the patient to a vertigo specialist, they can do some tests which will rule out BPPV, which will rule out central vertigo, and uh, then you can give migraine prophylaxis to these patients.
So what is the common age group for subarachnoid hemorrhage?
Subarachnoid hemorrhage, now there, as we know, there are the causes. I'll first tell you the subarachnoid hemorrhage causes. The commonest cause of subarachnoid hemorrhage is trauma, so that there is no age group for that. The other non-traumatic subarachnoid hemorrhage can be due to berry aneurysms or due to AV malformations. These are two other common causes of subarachnoid hemorrhage. Berry aneurysms can occur at any age. It's not old age. It's not young. Meaning young people can get subarachnoid hemorrhage due to rupture of berry aneurysms. So age group, I would say for berry aneurysm rupture can be young and can be old. Berry aneurysm can rupture at any time of your life. And yeah.
Yes, sir. So everybody is congratulating you on your talk, sir. A very useful and informative talk as usual. I don't see any more questions. Anyone in the panel has any more questions?
Sir, any drugs not to be given in Parkinson's disease patient?
Okay, thank you for the question. Again, reminded me of one more thing. I did not talk about in restless leg syndrome. Restless leg syndrome can be worsened by SSRIs, SNRIs, and tricyclic antidepressants. So any serotoninergic drug may worsen restless leg syndrome. So just remember that. You were asking about uh, drugs that can worsen
Any
what?
What
any
not
drugs
to be used?
uh,
What?
Parkinson.
not to be used in Parkinson's disease?
Let me think. One is Parkinson's disease. May the drugs that we use, levodopa, syndopa, they cause sometimes postural hypotension. So remember that drugs that can worsen postural hypotension may not be used in Parkinson's. For example, Parkinson patient may have a prostate problem, and these patients you should be careful in giving your tamsulosin or similar drugs, or start with a lower dose of tamsulosin, etc., and give a higher dose if necessary. Only if the patient tolerates. So postural hypotension you will have to take care of. Which other drugs? So any other drug that can have uh, uh,
I
dyskinesia as a
think
side effect.
gabapentinoids also should not be given in
I'm sure they
Parkinson's
should not.
disease.
Yeah, I'm sure they should not be given. I'm just wondering what additive side effect can they cause. Will they interfere with syndopa? No, they won't. But I'm sure they will cause side effects like dizziness, etc., which they will not tolerate. But I'm not sure if they will interfere with Parkinsonism treatment. If you know more, please do tell me about the.
Similar amitriptyline like tricyclic antidepressants should be avoided as far as possible in Parkinson's disease.
Agreed, absolutely. Any drug that has anticholinergic side effects should be avoided. Any drug that has, like antipsychotics, for example, they can aggravate the hallucinations of syndopa, the dyskinesis of syndopa, etc. Many patients of Parkinsonism have depression. They have many patients of Parkinsonism have dyskinesias. So drugs that you use for depression and dyskinesias, you have to be careful about not adding to the side effects. Again, I'm not an expert in this, maybe, but I can think that yeah, there'll be problems by giving tricyclics, definitely.
Thank you, sir. You have concluded the whole session very nicely. We have become now champion in neurology in OPD.
No, long way to go for all of us. But yeah, I hope that
So
it
many
acts as,
important tips, sir.
yeah, but I hope it acts as a primer and stimulates more study for all of us so that we can manage our patients better without unnecessary empiric therapy in many cases.
So on
Thank
YouTube,
you.
there is a request so that you can share the PPT at a later date
How do I
on
share it?
neurology. Today, I mean, it's fine with us if you're able to. So
No,
even
you
if
have
you
the
open
PPT.
it, you do share screen and open that page. It should open. Can try it, sir. We are waiting.
I will try it again. So even you have the PPT. I don't know if you can try yourself also.
Himali,
It is on your group and it is actually with the Rushil's team also. But I will give it to
yeah.
you again. So I put it on the team. Dr. Preeti, you have it now.
Okay.
I really do not know how to share it.
I am outside, sir. Dr. Vibhakar, can you try?
Oh, I also can't.
Okay, we are slightly handicapped.
Himali or Rushali?
Himali has
NS4
not
team.
been active. I don't know why. She was supposed to.
Yeah, anyway, I think we will share the PPT. If you can share it with your groups by WhatsApp,
Okay, sir.
the
We'll do
PPT
that.
is, the PPT is with you. So
Yes,
you
sir.
can probably, so it'll at least there'll be some points which I may have missed and will be there on the PPT.
Yes, sir.
Great. I'm coming back to the, yeah, sorry, I could not do that. I'm very, very sorry. Thank you so much, all of you, and I hope to see you again next month.
Yes, sir. On behalf of FFPAI, I extend my warm thanks, my heartfelt gratitude to Dr. Tushar Shah for accepting our invitation to give us a talk on this series. And today he's had his first of the series on neurology. I also thank our president, Dr. Pragnesh, Dr. Vibhakar for moderating the session, Dr. Sanjay, and Dr. Dhiren Mehta and NLA's core team. Last but not the least, thank you all the viewers from YouTube, Zoom, everyone. And sir, I have been continuously receiving congratulations and thanking messages for your excellent talk.
I'm sorry, I could not open YouTube, but I
Yeah.
hope that everybody enjoyed. And if there are any suggestions on YouTube only of what is the next system that you might want or any subject that you might want, please feel free to
Yes, sir.
post. Thank
Yes,
you.
sir.
Bye-bye.
Thank you very much, sir. Thank you, Dr. Vibhakar. Thank you, Dr.
Thank
Sanjay,
you.
Dr. Dhiren.
Thank you, sir.
Himali,
Yes, ma'am.
you can, are you able to share the PPT? No, no?
Ma'am, can you share me in WhatsApp group?
I think
Okay.
I have
No,
received
but I think
in
it's,
the WhatsApp group. I have just, I think, received. I don't know who posted.
it's
Dr.
sir only.
Tushar sir has posted, but to share the screen, we have to be given permission by endless code.
No, but give the PPT to Himali, and Himali will be able to
Yes,
share
ma'am.
it.
Wait. Yes, wait, sir.
Yeah, you got the PPT, I hope, Himali.
Yes, wait. I'm not for it.
Those who are watching on YouTube, we'll just try to give a link on YouTube also. Himali, can you put a link on YouTube also of the PPT?
Yes, wait. And sir, live ચાલુ જ રાખવાનું છે?
No, live ચાલુ રાખવાની જરૂર નથી. If you can put
Okay,
the
fine.
PPT on the YouTube, then we don't need. But at least people should know that it has been put. And are we keeping the video on YouTube for some time?
Yes, sir.
It is on, sir.
But
It is not closed yet.
No, I'm saying will the YouTube be available for tomorrow? For example, some people want to watch it later.
yes,
It
sir.
will be
It's
available, sir. Yes, sir.
it's available.
So send the link of the YouTube also to me so that I can
Yes,
I
sure,
can share it
sure,
with
sir.
people who have not seen.
Yes, sir. Sure, sir. I will share with you. But
Great.
yeah. Okay, fine.
I'll leave then. Thank you so much.
Okay, sir.
Yeah,
Thank
sure.
you very much, sir.
Bye.
I will send the YouTube link to you, sir, on the group only.
Understood. Yes, ma'am. Wait. હું PPT એક વખત શેર કરું છું તમે જુઓ. OBS માં નથી લખેલું. આ લાઈટો બંધ કરો.